Greetings, everybody. My name is Sirakov, and today I'm gonna show you a few slides about the recently introduced device called Nautilus. I don't have any disclosures. The very purpose of this presentation is to demonstrate our initial and limited experience with this device and to basically distinguish its unique features and properties. The device is, honestly, it's perfectly engineered as the Jules Verne's Navius arsenal, but however, the schematics in the design are slightly different though. The Nautilus device is a dedicated intrasaccular implant that, in my opinion, is a conceptual upgrade from the already available Piconus 2 Pulse Rider. However, it does not harbor any intraluminal implants, as you can see on the picture over here. Therefore, the operator and you don't need the so-called mandatory DAPT for the Nautilus implantation. The Nautilus device basically aims to fully reconstruct the neck, and it's only a single intrasaccular component, but it's really different from the already available web device and the Contra. It's fully resheathable, mounted on a wire, which makes the device really easy to deploy at the saccular aneurysm to be readjusted at the level of the neck. You can do that manually without any tension. As you can see on the video here on the left, here's where we push the Nautilus. The first few whoops actually behave like a like a really soft coil, like a finishing soft coil. When fully deployed, of course, you can manually retract the microcatheter and the whole system and readjust the Nautilus at the level of the neck as you, of course, desire. Now, speaking about cutting-edge technologies, that's a really interesting feature of the Nautilus implant. It's maybe it's due to the nitinol nature of the device. It behaves really differently in different temperatures. For example, that's the implant in 25 degrees Celsius, and that's the implant when it's inside the body temperature. It becomes a little bit more denser and a little bit, and it hardens a little bit just to make sure you have the enough support that it's needed to coil the aneurysm. But that very unique feature actually allows us to deploy it safely when it's inside a microcatheter and flushed with cold saline, and that over here is when it's fully deployed and inside the aneurysm at the body temperature. Now, what we suggest is basically that the implant is compatible with all the available 0.17 technology, but we suggest you go for the Headway 17 due to improved stability in our experience. Conceptualizing the technique, I'm gonna say you go for the biggest diameter of the aneurysm. You start to deploy somewhere around here. When you are fully satisfied with this position, you start to retract the device back up until the moment you have like maximum comfortability with the neck. When it comes to sizing and choosing the right device, we do recommend to oversize the implant with 0.5 millimeters over the diameter of the neck of the target aneurysm. The device is available in four different diameters, from 4 to up to 7 millimeters. Therefore, making all the like complex aneurysms we face on a regular basis like pretty much treatable. When you're satisfied with the position, when you position the implant at the level of the neck, when you have maximum comfortability, you proceed with navigating a second microcatheter through the central pore over here. That is used for the following coiling and the following coil mobilization. It's not that difficult. In our experience, in over 30 cases, we managed to do that in like a bunch of tries. We recommend you don't detach the mechanical implant so far, because just in case any migration or malposition occurs, you can reposition it manually. When you're satisfied with the position of the implant, or when you're satisfied with the first framing coil, or when you're done with the embolization at all, you can proceed to the mechanical detachment of the implant. Now, interestingly though, in our experience, we started to notice some really interesting off-label features of the device that I would like to share with you, and that's the semi-flow diverter effect that we noticed. You can see maybe because of the nitinol nature of the implant, the Nautilus actually acts as a semi-flow modulator over here. You can notice the stagnation of the contrast media right after we deploy the Nautilus alone at the level of the neck. Another thing, take it with a grain of salt, but as more you start to use it, as comfortable as it gets, you feel more confident to insert more and more coils. Maybe that's subjective, but it might be due to the fact that coils are no longer an issue when you're facing the neck of the aneurysm. Now that's the groundbreaking thing about the implant. These photos are taken from the really nice animal study that the company conducted, and they saw some biological evidence of active transformation and endothelial migration over the struts of the implant. I was kind of skeptical until the very moment when we saw progressive remodeling of the aneurysm that was caught with the Nautilus. You can see that's the that's the final angio during the embolization. We left some tiny contrast over here to, that's a residual for sure. And you can see the complete remodeling on the 6-month follow-up. The same can be seen over here. I think that's the most representative case over here. That's a small MCA aneurysm that we left a tiny remnant over here at the level of the Nautilus. And you can see the complete obliteration with some evidence, some geographic evidence of biological remodeling. You can see that defect filling over here next to the neck. I think that's the radiological evidence of like endothelium migration over the strands of the implant, which is fascinating. So in summary, our experience includes over 30 patients so far. We try to embolize both ruptured and unruptured aneurysms. With diameters ranging from 3 to 17 millimeters in largely wide necks, I would say. The aneurysms treated were distributed across this cerebral circle in NACOM location, MCA bifurcation, basilar artery, and PCOM predominantly. We were really satisfied with the results we got back then. No technical complications, no device-related complications actually, and the occlusion rates were really surprisingly high. I think that was what bothered us the most. We issued, and we were fortunate enough to have the independent imaging core lab that basically confirmed the really impressive occlusion rates at the follow-up and the initial intervention. So for your entertainment, I'm going to show a bunch of cases we managed to successfully embolize, and that's a bifurcation MCA aneurysm that I already showed you, but that's the technical part of the procedure. It's a really tricky aneurysm with both vessels incorporated at the level of the neck. What we did over here was we deployed the Nautilus inside the sac, safely navigated with a microcatheter, and started to embolize with embolizational coils. We felt confident though. The device was actually giving enough support to insert more and more coils. However, this was the very first case, I guess, and we left a tiny remnant over here. And as you can see on the follow-up, on 6-month follow-up, there was no contrast filling inside the aneurysm nor the neck. That's a good result, in my opinion. Another case, but this time an aneurysm located at the basilar bifurcation. An ugly-looking biovulated aneurysm that we treated with Nautilus. The implant was delivered at the equatorial plane of the aneurysm, then slowly retracted at the level of the neck when we had like maximum protection over the parent branches. We navigated through the central pore with a coiling microcatheter, and we filled the aneurysm up. Another beautiful case, really cool one. That's a complex in wide neck ICA aneurysm. You can see what we did over here. We implanted the Nautilus, and that's the so-called stagnation that I already showed you. The Nautilus actually provides even more stability once you start to fill with more and more coils, because the coils are actually pushing the device to the aneurysm neck and increasing its compliance even further beyond. So that's another case. That's a ruptured MCA aneurysm. What we did over here as well was to deploy the device, set up the microcatheter, and start to embolize. You can see that both branches are really close to the aneurysm neck, and without any reconstructional device, I would say that's pretty much really hard task to conduct. You can see that over here, I left small portion of contrast, small portion of residual filling. And you can see on the final 6 months follow-up, there is no contrast at all. So I think that these flow modulating properties of the device and the fact that there is cell migration over the implant, actually, it's really fascinating, and it helps the aneurysm to heal. Another case of a large ACOM-A aneurysm, really awful anatomy for me. What we did over here, we deployed the device, retracted back, and then filled the aneurysm with coils. I think that's the 6 months follow-up as well. Some residuals, I think the final embryo yielded Raymond Roy class 2, but we managed to obtain full obliteration of the aneurysm on the 6-month control. Large ACOM-A aneurysm, a patient, a young female patient with SAH. That's a wonderful example. The ACOM-A complex in the A1 was slightly spasmatic, if you ask me. And what we did over here was we deployed the Nautilus, safely navigated through, kept the Nautilus attached up to the very last moment, and we called the aneurysm with a wonderful result. There was some slight residual as well of the aneurysm on the final DSA with complete remodeling on the 6-month follow-up. Large MCA aneurysm, you can with the more and more we started to use the device, we felt confident to deploy to use the technique and deploy the device in tinier aneurysm that is shown over here. Nautilus inserted into the equatorial plane, retracted back at the level of the neck, navigation with the microcatheter inside the aneurysm, and we managed to successfully embolize the aneurysm. Look, that's the 6-month control, a complete amputation of the aneurysm from the cerebral circulation. Another MCA aneurysm in a rupture case scenario. All of these cases were conducted without any dual antiplatelets. We believe in that because there are no intraluminal implants. What we did over here, that's a really tricky case with a really an awful branch coming from the aneurysm sac, and the aneurysm is actually located on the dominant MCA vessel. What we did over here was we deployed the Nautilus, felt comfortable to retract it back, confirmed that there is no blockage of the flow of the parent artery, and we code the aneurysm. Another PCOM example in a rupture case scenario. This is where we started to notice that we can increase the coil basket and the coil mass with the further insertion of coils. As you can see, we felt confident to coil even the neck over here. And that's the final anterior result, complete obliteration of the aneurysm. So in conclusion, I think the device is extremely new, and it's worth a shot to try it. I would definitely recommend it to the audience. It has a hollow learning curve, and you should definitely give it a go. So far, it didn't yield any complications that are device related. We didn't observe any dreadful interaction between the coils and the Nautilus, no detachment issues. And I think it's a really good device that you should give it a go. So thank you very much for the presentation. See ya.